Hi, my name is James Connor. I'm a colon and rectal surgeon with the Sacramento Colon and Rectal Surgery Medical Group. And today we're going to be talking about a very common condition that we see in our practice called anal fissure. Anal fissures, and particularly my clinic day, usually I will see one or two patients with this particular condition. Oftentimes the symptoms of an anal fissure can be confused with hemorrhoids because probably the most common symptom that I see patients will have with fissures is pain associated with the actual bowel movement itself. And the onset can be rather abrupt. Usually patients will have related to me a history of frequent loose diarrhea or a really constipated and hard stool. And those are probably the most common two reasons why I see this condition. And then afterwards, each subsequent bowel movement after that results in more pain. There can be some swelling. Bleeding can also be present too. And those are a lot of symptoms that can be associated with hemorrhoids. So it's oftentimes hard for patients to differentiate the two conditions, and that's where we come in as colorectal surgeons. When it comes to treatment for anal fissures and conditions such as this, we really try to take a non-surgical approach first. And oftentimes, actually, a great deal of patients will improve their anal fissures with a medical treatment regimen, which usually is focused around fiber intake and a good amount of water intake. And if one suffers from constipation, usually a stool softener such as Miralax would suffice over a stimulant laxative like Senna, because laxatives such as Miralax would actually add more water to the stool rather than forcefully propel the stool through an already irritated fissure region. So fiber therapy, increasing your fiber intake, can really help modify the stool so that it tends to be less traumatic and allows for better fissure healing potential. So usually we try to get patients to shoot for a 25-30 gram of fiber per day, in addition to water intake, which I usually recommend to be between 6 and 8 glasses of water, excluding alcohol or coffee in that total. So you can find many charts for fiber intake online, but for just a short reference, usually a small, medium-sized apple would have about 4.5 grams of fiber in it. And you basically do the math to get up to that number, and that will really help a lot. There's a lot of soluble fiber supplements over the counter. Metamucil, Citracel, the most common ones. Metamucil sometimes gives patients a little bit of bloating, so if you experience that, it's usually temporary, or you can also do Citracel, which tends to have less of a bloating side effect. So taking fiber, taking those soluble fiber supplements and stool softeners oftentimes will result in fissure healing in a great deal of patients. Patients will unfortunately have symptoms that persist even several weeks longer, and that becomes a condition known as chronic anal fissure, and that's where we start to come in with our professional advice and help to try to treat this particular problem. And usually for us, again, once we talk about prescribed treatments, we're not talking about surgery up front. Usually patients in my practice are going to be utilizing a topical ointment, which is obtained at a compounding pharmacy, not a regular pharmacy, and that usually contains a calcium channel blocker like nifedipine or diltiazem. There's also nitroglycerin, but oftentimes patients may experience some headaches as a side effect with some of these compounds, but usually nitroglycerin is probably the more common one. So I'll prescribe patients nifedipine or diltiazem usually as a start. And it's actually a pretty simple treatment process. Usually we'll have patients applying the ointment to the anal area, usually after their bowel movement of the day in the morning, usually that time, or in the evening, usually for twice per day. And if you get a third time, usually in the middle of the day, that would also be beneficial. So a 3 time a day would be optimal, but if it's 2 times a day is all you can get, then that's okay. So usually I'll have patients try that treatment routine religiously for a time period of 4 to 6 weeks, at usually which I will see you in the office for a follow-up and determine if there's any fissure healing. At that point in time, we can determine whether or not to continue the cream therapy, or if it seems that the fissure really is not responding to therapy, then we can proceed to interventions. The 2 major interventions for anal fissures, the ones that we use in our practice, are Botox injections and sphincterotomy, lateral internal sphincterotomy, which is the official name of the procedure. So Botox injections have been a relatively new treatment option, and usually for me is not going to be my first go-to when it comes to surgical treatments unless a patient has incontinence or is at a higher risk of incontinence. Usually Botox injections work by actually relaxing the internal anal sphincter, which is something that you cannot voluntarily relax. Your external sphincter you can, but your internal sphincter you cannot. So You actually go for a same-day surgery under a brief light anesthetic. The Botox is injected, and it's usually about a 10-minute procedure. You get to go home the same day. The recovery is very, very quick. Usually folks are back to work within a day or two. Usually if the Botox is going to achieve success, I quote patients about a 66% success rate in my practice, and patients will experience fissure healing and usually symptom resolution between 2 and 4 weeks, again, following up with you to determine if there has been a response to therapy. Moving on to surgical management, that is basically the tried and true method. It's been around for many years. Probably the one question and concern I get about sphincterotomy, which actually means a literal small incision made on the anal sphincter muscle itself, is patients will ask me, well, am I going to be incontinent from that particular procedure? And actually the incontinence rate is quite low with a sphincterotomy procedure in a well-selected patient, and that usually I would cite around a 1 to 3% risk of incontinence, which usually would be minor, such as incontinence to gas rather than full stool incontinence. But the surgery itself is actually successful in well over 90% of patients. And that surgery, even though it is an incision on the sphincter muscle, usually carries a short recovery as well. That is also a same-day surgery procedure, usually conducted in about a 20 to 30-minute period. You go home the same day, and the recovery also is short and low risk as far as complications are concerned. So that's just a brief overview of anal fissures from medical to surgical treatments. If you had any other questions about that or wanted to seek consultation with us or one of my partners, feel free to visit us on the website or give us a call. Thanks.